Welcome back to Healthline. Again, I am your host, Gregory, joined by Dr. Anthony Cardillo. I am loving having you here.
It's great to be here.
Do you ever feel like you have to play God?
It's a really difficult question to answer. I'll tell you why. I think the public has the expectation that we are going to make decisions as though we were God. Okay? People come into the emergency department, for example, with their child, and they'll say, I'll give you a specific example of a patient who said, "This is my only son and my namesake. Please tell me he's going to be okay." I don't have a crystal ball. I can use my medical judgment, which is a combination of my educational background, my skill set, my clinical acumen, and try to make the best judgment possible. But even with that being said, when your child falls down and hits their head, unless you start doing extensive workups, you don't know what's going on inside. And you have to make a clinical judgment. But people want us to be God. They want us to make that decision.
And they hang on to everything that you... Is that hard for you?
It's very hard, because at the same time, society is no longer accepting the notion that doctors might be playing God. In fact, there's a whole revolution against that now, where the doctors are sometimes no longer the good guys. And they don't want us to think we're playing God. And we're not. We're just trying to make judgments, medical judgments. But when someone's life is hanging in the balance, they expect us to be able to look into that crystal ball and know the answer. And some people call that playing God. Other people call that, predicting the future. But medicine is not black and white. It's a huge scale of gray in between. And sometimes it is black and white. People come in and they're critically ill and we know exactly what to do. Other times people come with very minor illnesses and we discharge them home and there's no problems. But there are patients that come in with a whole spectrum of disease processes. You may come to the ER with a headache, for example.
Sure.
And it may be the first day of a developing meningitis. Well, your headache is going to be identical to the guy in the bed next door who has a migraine headache. And trying to decipher the subtle cues and clues between those two patients is why my hair is getting gray, at a very early age, because it is incredibly stressful.
Well,
because illness starts the same, whether it's severe or minor.
One thing I just want to say that you said that was fantastic is that you said you were just making a judgment. And what you also said before the break is that we're just human beings, and you are trained to make those judgment calls.
Right.
One thing that I did not say, folks, please find out where your closest emergency department is. Glendale Adventist Medical Center is on the corner of Chevy Chase and Sinclair. As a family, find out how to get there, because the last thing you need to do is get lost when your life is hanging in the balance.
It may sound paranoid, but when I travel with my family, before I go to a new city, I just do a quick Google search and I find out where the local hospitals are, because like you said, when that emergency happens, it's going to happen at the most inopportune time. And getting to the ER yourself may be faster than calling 911.
Sure. Okay. Are you ready for my game, doctor? Name that illness. And if you have pen and paper, pay attention.
Is there a prize for this at the end?
Oh, it is. But behind door 2. 2. Someone comes into the ER and they have these symptoms. Scratchy throat, sneezing, wheezing, a nasally, watery discharge. What is that?
It could be a lot of things. Herein lies our problem.
Okay.
This can be the beginning, the first day, the early stages of influenza or swine flu, or it could be a simple case of rhinitis, a simple case of an upper respiratory tract infection. It could be allergic rhinitis. It could be an early, just simple cold. Or it could be the early stages of something more serious. Herein lies the dilemma for us as doctors.
Well, ding, 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 ding. So far, Carol Merrill, so far good. Okay. Next. A burning, gnawing feeling in the stomach that lasts from 30 minutes to at least 3 hours. What is that?
Another good question. A lot of people come to the ER with that similar complaint. If you're a 25-year-old male and you have a burning, gnawing sensation right here in the center of your stomach, and you perhaps drink 3 or 4 beers per day, that could certainly be pancreatitis. Or if you're a little bit older and you smoke tobacco and drink a little alcohol, you could have a gastric ulcer. If you're 55 years old and smoke 2 packs of cigarettes per day and have a family history of coronary artery disease, that pain could be from a myocardial infarction. Again, these cases clearly demonstrate our dilemma in the emergency department, because these vague symptoms, a gnawing, burning sensation in the pit of your stomach, in the epigastrium we call it here, can mean many things. It depends on the patient's clinical presentation and their historical data and their age group.
But you were saying as well that in the watery discharge and the sneezing and the wheezing, you said it could be a cold, could be influenza, could be the swine flu. Mm-hmm. If you have to make that decision like that, would the information then from the patient be more helpful to you?
Yes, it's very helpful. Everything the patient tells us, and also what we're doing in emergency medicine is we get very good at, in a blink of an eye, evaluating a patient, and a lot of data is coming in. Their clinical status, how they look, are they lethargic, are they alert, are they oriented, all the different subtle clues that we're picking up and looking at their body habitus. Are they sweating? Are they febrile? All these little clues that we're picking up as we're talking to the patient that make us think serious, not serious, ill, not ill, admit, discharge. That's where our big defining moment is. Are we admitting the patient to the hospital, sending them home? And a lot of it is nonverbal communication that we're picking up with.
Wrapping up, what is the most important thing you can say to anybody that goes to the ER?
Number one, know where your ER is before you come. But number two, know your medical history, know what medications you're taking, know your family history, and try to be a good historian. As I tell people, imagine you just came out of a movie theater and you saw a movie, and your friend asks you, "Oh, tell me about this movie." Well, you'd probably start in a very logical manner from the beginning of the movie, telling them the story. When you come to the ER, present it the same way. When you come to the ER with abdominal pain, be prepared to tell the physician exactly when the pain started, how it started, what the symptoms have been, along with your past medical history. Just know that you're coming to the ER to be a good historian, to help us diagnose you.
I love that, because most people don't look at it that way. They just go in and say, "Please fix me."
Exactly.
Thank you so much for being here, and thank you for sharing all the wonderful anecdotes you shared with me and our viewer about the emergency department.
It's a pleasure to be here.
Dr. Cardillo, one last question. Emergency rooms are closing all over the country.
Sadly, yes.
Talk to me about the wait time in emergency rooms.
Yeah. Wait times have become a big issue for all emergency departments, and we try to minimize that as much as possible, especially because you never know what is outside in the waiting room lurking. And so we've tried to develop multiple strategies to decrease wait times for patients. One strategy that we do at Glendale Adventist is we have placed an EMT into our waiting room to help triage patients and better place them in a position to get into the emergency department faster. Once you get into the emergency department, there are many strategies we are implementing almost monthly to try to expedite the throughput from when a patient walks into the department to when they leave or get admitted. And what patients have to understand is that if I can't come to your bedside and you're waiting, it's not because we're sitting back watching TV. It's because we're managing other critically ill patients. So our role in expediting that flow is critically important, and the hospital's role. But it's also up to the patient to be patient. And sometimes just having to wait until we get back to their chart and review their data. We're not just changing oil in a car here, we're making critical life decisions, and one piece of data that's missed can be disastrous. So we are working diligently to try to reduce wait times and implementing strategies. We're also working diligently to increase throughput in all the departments. And there are a lot of strategies that we use to do that.
Thank you so much. Will you come back and spend time with me here?
Most certainly will.
It was an absolute pleasure.
Thank you.
Thank you for joining us tonight on Healthline. We talked about emergency care. I hope you wrote down everything you heard that could possibly save your life. Go get a medication ID card. Call 818-409-8100.